afternoon, everybody. Thank you very, very much for coming. My name is Dr. Catherine Lambus. I'm a local physician and a state council member with SPAN, Ohio. And for those of you who don't know much about SPAN, SPAN is Single Payer Action Network Ohio. And we are a state-based group that is working for legislation in Ohio and nationwide for a single-payer type healthcare system, either state by state or on a national level. So this is our first foray. Today is a National Day of Action for Healthcare, and we're proud that we've been able to coordinate this on April 8th to coincide with the other national events that are going on. We have three speakers today. We have the first speaker here is Dr. Matt Noordsij-Jones. He's the regional coordinator for this area of Ohio for SPAN Ohio, also a state council member. He is a local physician, originally from Madison, Wisconsin, did his medical school at Medical College of Wisconsin, and then came to Wright State University to do internal medicine and pediatric residency. He's now a community health center physician practicing primary care. So today we'll start with Dr. NJ.
Okay. Make sure that's still working up there. Well, thank you guys so much for coming out today. My name's NJ, like she mentioned. What I wanted to talk about, and we're going to have three people coming up here to talk a little bit today, so I'm going to try not to overlap as much as I can. But I want to give kind of just a little bit of background on the U.S. healthcare system and kind of where we are right now, a little bit about what we've been doing and talking about lately, and a little bit about how we compare to other countries in the world, because that's really important when we start talking about healthcare, because we do it very differently from most other countries. And so to start with the U.S. healthcare system, I always like this slide just because it shows the complexity of our kind of mashed together system that came together over 80, 100 years now of trying to kind of mash together different types of healthcare systems. I'm pretty sure it runs entirely on paper. If you look at my office, it certainly seems like it does, and it really doesn't work very efficiently. So if we look at how much money we spend on our healthcare system, and this will come back to later too, but our public health spending right now dwarfs most other countries' total spending on healthcare. And if you add in what we pay for in deductibles and co-pays and premiums, that's that private section, the orange part there, we spend a ridiculous amount on healthcare, twice as much as most other countries in the world, and certainly more than the next largest spender. So what do we get for that? What do we come away with when we spend so much money on our healthcare? Not a whole lot. We have a worse life expectancy than any other developed country in the world. We have much higher infant mortality rates, and that's something that really pertains to this part of Ohio as well, because Ohio is very far down on infant mortality when you look at other states, and this part of Ohio is particularly bad, and we'll talk some more about that as we go into. Our maternal mortality also much higher. We don't do very well compared to other countries. And that's actually been increasing a lot lately. I put this slide up actually as just kind of an aside. So Texas, you notice, has had a huge increase from 2000 to 2014 in maternal mortality. And I just wanted to throw out a comment there that we really need women's health care clinics. And this is one of the things that Texas is causing some problems with. But anyway. And now that is just looking at us as a whole. So now we also have to look at that subset of people. How do we do with our economic and health inequality? Even Americans who have above average incomes actually have worse access to care. This looks at the average from 10 other developed countries and our access to care versus theirs. So you hear a lot about these waiting lines in other countries, but it's really not true. Our wait period for doctors is about equal to the mean of these 10 other nations. This is a study done in the New England Journal of Medicine. Our wait for not getting doctor's visits that we need, not getting tests done that we need, or not filling prescriptions is way higher than these other countries. And that's for people who have actually high incomes. That's for people who should have really good access to care based on how we do things in our country. So if you look at lower income people, it gets worse and worse for healthcare outcomes. So if you look at life expectancy between the richest and the poorest in the US, this is going from the poorest on my side to the richest on the other side. There's a 10-year difference for life expectancy for women and a 15-year difference for life expectancy for men. We are really not doing well for the poorest in our country, and that life expectancy gap has been getting worse. This only goes up to 2001, but there's actually more data here for 2010 showing that the poor in this country are having shorter life expectancies actually than back in 1980. So this is how long you live after you turn 50 back in 1980 versus 2010. It's getting worse for poor people. It's getting a lot better for people who are healthy or people who are rich, because we have a lot more healthcare out there. It's just not getting to most of the people in this country. The other thing I want to touch base on really quick is the persistent racial inequalities that go along with healthcare. This is, of course, a quote many of you have probably seen before, but it's always bears repeating. It's a fantastic Dr. Martin Luther King Jr. quote. Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. And it is, like I said, a very important thing. And if you look at any marker really that you want to for health quality in this country, it's worse for minorities. So if you look at OB care and outcomes, infant mortality is even higher. Maternal mortality is even higher, and we already saw how bad that was to begin with. Getting things that you should get, like flu shots, or being told that there's testing that you can have for genetic testing, doesn't tend to happen in minority communities. And all of this causes worse outcomes. Minority children and youth get fewer psychiatric visits, and Black Americans die younger than white Americans. And there's a lot of things that go into this, of course. There's the institutional racism that we are still fighting and need to do a lot more about. But if you just change healthcare, so if you just look at giving everyone access to care like the VA system does, they did a longitudinal study, 3 million vets, and looked at the differences between races and between blacks and whites for total mortality, new heart attacks, and new strokes, and that difference goes away. It turns out that people, when given access to healthcare, we don't have all of the differences in the racial differences that we see in our society right now. So the short takeaway for this is that we spend a lot more than other countries do, and we don't live healthier, we don't save more lives than other countries do for all that money that we're spending. So that brings us to the healthcare debate that we just had back in 2009, 2010, before the ACA. And what we talked a lot about then was the uninsured rate. So this is a chart just showing the uninsured rate in the US over time. After World War II, people started getting insured. That insurance rate dropped down to 1965 when we introduced Medicare and Medicaid. And we had a huge drop in the uninsured rate, which was fantastic. And that number kind of kept going downward through the 70s. In the 80s, we decided we're going to do a little bit more private health insurance. We're going to start to ramp up the competition in health insurance in the private markets, and our uninsured rate started going up and up and up until we get to that next drop off down there where you see where the ACA was introduced, and we had a really big cut again in the number of uninsured in this country. And if you look at the yellow, that's the CBO, the Congressional Budget Office's estimate for how healthcare is going to go if we keep doing what we're doing. And I'm not going to stop on what Dr. Don Nguyen is going to be talking about, but there's, of course, other proposals out there, and that curve would look a lot different depending on what we decide to do in the future. So he'll talk a little bit more about that. But the ACA cut uninsurance amongst Hispanics, blacks, and whites all by about a third. It reduced the number of Americans that said that they were unable to afford care back to levels that we hadn't seen since 2000, which is really important. It also increased access to care. So looking at people complaining that they weren't able to get into their doctor or to get tests or to get medicines, it decreased that to levels that we hadn't seen since before 2005 as well. So these are all really important things that the ACA did. But I do want to keep in mind, and this is an important thing, there was a study done in 2009 at Harvard, it was published in the American Journal of Public Health, that looked at how many Americans die each year just due to not being insured. Before the ACA, we were about 44,000 people a year were dying just because they weren't insured. Now, that number in 2015 is estimated to be about 29,000 people. That's a lot better, without a doubt, but that's still abysmal. If there was anything else, if terrorist attacks killed 29,000 people in this country a year, you can bet we would have invaded a couple of countries by now. Like, that's insane, but we keep going along with it. We need to fix this problem. So again, the takeaway is we spend a lot more, we don't live healthier, save more lives. Many of us don't have insurance and still don't have insurance. But the other thing is being insured enough? So, okay, we get insurance for people. Is that gonna really fix the problems that we have? It's a rhetorical question, of course, so the answer is no, not necessarily. When we look at bankruptcies in this country, many of you may also know that most bankruptcies in this country happen to people because of healthcare problems, because of the healthcare bills that they get. But what a lot of people don't realize is that Most of those people who go bankrupt because of healthcare problems had insurance when their healthcare problems first started. So insurance is not saving everybody. Only about 22% were actually completely uninsured when their healthcare problems started. Most of those people had private insurance or some other form of insurance that ended up not covering those bills that they needed to be covered, and they end up going bankrupt because of their healthcare problems. There's a lot of reasons for this, but one of the big ones that everybody is running into now is that deductibles are going up and up and up. And I was actually shocked to realize, as low as deductibles were back in 2006, only about 10% of people had a deductible that was over $1,000 for people who worked and had health insurance through their work. Now that number is most people. Over 50% of people right now who have health insurance through their work have deductibles that are higher than $1,000, and that is way too much to have to pay to be able to get health care, and it means that a lot of people are going without health care. So high deductibles have been shown to reduce people actually getting the medical care they need. So there's been this study actually looked at whether there was evidence that people start shopping around more, maybe go for lower cost procedures, try to find something that's more efficient, right? That's what it's supposed to do. But there's no evidence that that actually happens. What people just do is they go without the health care that they need to get. And so these higher deductibles are making people sicker without making our health insurance system more efficient. If you look at co-payments that Medicare sometimes puts on people for office visits, all that it's shown to do is actually it does decrease office visits. People stop going to the doctor because their co-pays are still high, but it actually increases hospital admissions and it increases the number of days they stay in the hospital, because what they're not going to the doctor for are those things that they need to be in the doctor for checking on their high blood pressure and checking on their diabetes, and then they end up sick and in the hospital, and we spend tens of thousands of dollars for something that was only put off for, you know, a $40 copay or whatever that we really didn't need to have there. So this is why we spend so much more. These slides basically say the same sort of thing, that people tend to, not shockingly, not get care when they're having a heart attack if they're underinsured or uninsured. Drug deductibles also reduce the need for, or the use of medications like we were just talking about, so people with diabetes meds and blood pressure meds don't tend to get them. Because they're not getting their medicines, this is for kids with asthma. Kids with asthma who have co-pays on their medicines don't get them, and they end up getting admitted a lot more because they're not getting their medicines, which is a disaster. So what that comes down to is we have much higher out-of-pocket payments than any other developed country in the world, again, because for some reason we hope that it will make people use their health insurance more wisely when they have skin in the game. But what it really ends up doing, all the studies have shown that they just use their health care less and get sicker for it. So again, the takeaway is we spend more, we don't save lives, many of us don't have insurance, and the insurance we have is covering less and costing us more. So going back to that slide we had at the beginning, the public spending for US healthcare is really high. So where is that money all going to then, if we're not really getting good care and we're not really using the doctor as much as we need to be? The answer that a lot of people try to give is that we're just fatter, we smoke more, we're lazier, we don't do things that other countries do to help their health out. But that's really not true. So if you look at smoking prevalence, we actually smoke less than most European countries do. France apparently smokes a ridiculous amount. We are younger than most other countries, most European countries I should say are. We tend to spend less days in hospitals, although we're about even with the Canadians for how many days we spend in the hospital. We don't go to see the doctor very much. I have no idea. So Japan, blows my mind every time I see it. Japan sees the doctor, on average, a Japanese person sees the doctor once a month, which means that there are high-end users that must see the doctor like literally every week anyway, but that's neither here nor there. We don't see the doctor very much because of the things we've talked about. We also don't have very many nurses, which, as the wonderful people from NNU will point out, is something we really need to work on. We need more care in our hospitals and our doctor's offices. We don't tend to get more procedures done. We don't get more hip replacements than these other countries do. We do have a lot more PET scanners for some reason, which I don't think is necessarily a good thing, but is another issue. We're less likely to get things like transplants when when we have renal failure, when we're on dialysis. So it's not that we're sicker or that we are older. So where is that money going? And this is a great slide. This is where that money is going. So this slide shows us the growth in the number of physicians since the 1970s till now versus the growth in the number of administration. in our hospitals and doctors' offices and our insurance companies, and that is insane. So that's a 3,000% higher number of people just pushing paper, and that is where a lot of our money goes to. So we're going to look at a couple of different parts really quick, and then I'm going to hand this over. But private insurance companies have really high overheads. So part of what the ACA did was said to private insurance companies, you can't spend more than 20% of the money that you take in premiums on anything but healthcare. You have to put most of that towards the patients, and that was a stretch for some of them. They had to put rebate checks in the mail to give money back because they didn't do it. So they have really high overheads. Medicare has a 2 or 3% overhead. So we already have a program in this country that can do things with a very low overhead. And if you look at the insurance overhead for other countries, you see the same thing. The US spends 3 times as much as these European countries just in terms of those insurance overheads. Some of that goes to things like CEO pay. So I'm sure none of you would balk at a salary of $80,000 a day. But it goes to things like paying for, so an insurance company's incentive, and I'm not saying that this is bad, they're there as a for-profit company, they're there to make money for their shareholders. So what they want to do is they want to take in money in premiums and copays and deductibles, and they want to not spend it, because that's what they're there to do. And so they employ thousands of people to deny care to people, and that's why doctors' offices have to spend so much money trying to get care from them, because they don't want to let that go. And so this puts a lot more money in too, not just the salaries that go to their CEOs, although that's a problem as well. Then we look at drug companies. Drug companies in the US we spend a lot of money, I should say, on drugs. The US actually spends the most compared to other countries. Now, one of the things that is commonly brought up is that, well, we need to spend all that money because otherwise they wouldn't be able to make new drugs for us, is the problem. See, they need all that money for the drugs that they make. But when you look at it, drug company profits are way higher than other company profits. They make a ridiculous amount of money off of the drugs that they make. And they don't put a lot of that money into research and development. So they actually spend more, almost 3 times as much on marketing than they do on research and development, and they, even after taxes, have profits of 18%. They are making more than enough money to make new drugs. Most of our drugs are actually developed in universities by grants and stuff like that from the NIH, which is a really important thing to support, by the way. But this is not something that we need to be doing. What we don't do in this country is we don't negotiate for drugs en masse like we could. And that's something that people with Medicare Part D have run into a lot, because it's legally, Medicare is not allowed to negotiate for for cheaper drug prices, and we could be. And with a single payer system, we would be, and we would have much, much cheaper drugs. The other thing is looking at hospital and doctor overhead. I only leave this in because I hate paperwork. But doctors in the US spend twice as much time on EHR and desk work as with patients, is what this study came out to. That seems like a lot, it is a lot. But doctors' offices, because of all of the hassle of trying to get insurance companies to cover things, have to employ whole teams of people just to talk, to try to get prior authorizations, to submit paperwork. And so the percent of primary care docs in different countries saying that they have a tough time getting approvals is way higher in the US. And because of that, we spend a lot more money on office expenses to try to get those things done. The same is true for hospital billing. Hospitals have the same problems. They actually employ more people in hospitals now to do the billing and the insurance and to do all the administration than they do for providers. And that's crazy, because that's not what hospitals are there for, but it's the way we've set up the system. And if you look at that, so the overall administrative cost per capita, this is just comparing the US to the Canadian system, is, I mean, it's astronomical. It's not something that really can be defended in any reasonable way. So the important thing, though, after my most depressing part of the talk, is that we can fix this, that there are other ways to do this. They're going to talk to you a little bit more about that. That's enough graphs for a while. But if you have questions afterwards, we'll talk some more too. Thank you guys so much for being here.
Our next speaker is Dr. Donald Nguyen. He's a local surgeon in Ohio, here in Dayton. He's co-director for Doctors for America, which is a grassroots organization representing over 16,000 members of doctors, medical students who are fighting for fundamental right to health care affordability. There's high outcome care and equality in care. And he has been recognized for his healthcare activism as the 2016 Outstanding Healthcare Leader by Universal Healthcare Action Network Ohio, or UHCAN Ohio. and has as the recipient of the 2014 Humanitarian Award of the National Conference for Community and Justice of Greater Dayton. Please welcome Dr. Donald Wynn.
Well, thank you, Kathy, and thank you for inviting me to speak at this wonderful event. Thank you to SPAN, if we can get the slides to work. I think that what NJ's presentation, if you could summarize it, and that is every single slide that you have heard so far, that you've seen so far, could actually be a topic of discussion in terms of what you can do to fix this problem, right? So, for example, this slide where the doctors, the graph is down here, and the number of administrators, the number of costs, the number of dollars that are going into administration and so forth is rising. What is that you can do to change that, divert that money to health care, to patient care, rather than to, we call it pencil pushers or whatever. What you can do regarding the issues of high deductibles, for example, that is considered by some to be the biggest scam of the century, and some people have also called it the new pre-existing condition. So, but if we did that, we could actually do a lot to fix the healthcare system, because every single slide that NJ showed you basically illustrates a huge problem that we're seeing in healthcare today. So this is a famous quote, and I'm sorry I have to repeat it because I think it's worth repeating it. And the word discrimination is not commonly put in the quote, but I think one of the original statements from Dr. Martin Luther King Jr. is that he said, of all the forms of discrimination and inequality, injustice in healthcare is the most shocking and inhuman, not inhumane. And then also because it often results in physical death. And that's the last part that also not very many people give him credit for. But that's what drives me. I think that of all of the quotes that Martin Luther King Jr. has said, I think that resonates the most to me. And partly it's because I'm a physician. So the Affordable Care Act, or Obamacare, was passed in 2010. And I think it's really kind of boring maybe to you so far, because you've heard all of the things, but perhaps it should remind us of what we have had over the last 7 years. So more people now have coverage that previously were not insured. The uninsured rate is like the lowest. The healthcare cost curve has been affected. It's not coming down. It's going up, but it's still going up. But the tangential, the first derivative of the curve is leveling off. So with the federal exchanges, people are now able to go and get their plans, buy their plans, and if they're not a federal exchange and a state exchange, no more pre-existing conditions, but we'll talk more about that. So that's so far, as of today, that clause is still working, and that is you can no longer discriminate against patients because of a pre-existing conditions. And the pre-existing conditions, and there's a graph that NJ showed, literally as Medicaid, Medicare Act was passed and the number of uninsured dropped, but then it kept rising, the uninsured kept rising until ACA was passed. And the reason for that is that insurance companies discovered that you actually can just not cover patients who have a sickness, because it's a lot cheaper especially if you have cancer or chronic diseases. And this is why over the years suddenly more and more people were weeded out because of pre-existing condition. Like if you're on a drug like acne drug, it's considered to be a pre-existing condition, because a certain acne drug can cause you to have liver failure. If you have liver failure, then you need liver transplant. Liver transplant is pretty expensive. So if you're taking this medicine for this acne and the rest of your body is very, very healthy, you can be labeled as a pre-existing condition and you will not find coverage anywhere. If you're a woman, you could actually become pregnant, or you can become a spousal abuse victim. So you go to the ER, you get punched in the face, and then you get all kinds of injuries. It costs money. So that's why a woman is considered to be a pre-existing condition. So it's kind of a crazy thing, right? And One of the more popular provisions that kicked in was staying on your parents' plan until age of 26, and that makes sense. A lot of young adults got on board right away. Hospitals suddenly treating all of these young people that went skateboarding and then broke their ankle, and now suddenly they are covered instead of being an uninsured person. Seniors, Medicare, the Affordable Care Act got better, made Medicare stronger, more sustainable. Medicare with seniors, recipients can get preventative care, all kinds of good things. It's not a job killer, as famously mentioned by Ted Cruz. So, but all of these things, like preventative care, Dr. Kathy Lambers talked about preventative care in women's health, in children. 26 preventive care services are free. All of those things are very, very important. But let's make no mistake, the Affordable Care, Obamacare, has also lots of warts, right? Lots of warts. And but we can work on those warts. There are wart treatments, wart creams that you can put on and make them go away. So Trump care, some people call it Trump care. I don't even think that Trump worked on any of this thing. I think that he just came on and he said, well, let's do something to repeal this. But people call it Trump care and give him credit, but actually it's called the American Health Care Act, or AHCA. A couple of weeks ago I gave a talk about what would happen if Obamacare is repealed. Well, I changed the title now, it becomes Trump care. So the CBO predicted at least 24 million people will lose coverage, and mainly because of the subsidies and so forth that will be taken away. So that's 1 out of 10. Lots of these patients actually are working families, like 80% of them, and many of them are also between the age of 18 and 34. The uninsured rate will go up, will double. There will be lots and lots of jobs lost. Uncompensated care will be swallowed by hospitals, by providers. Hospitals, the Ohio Hospital Association, the Federation of Hospital Associations around the country commissioned this law firm and did all kinds of studies, financial studies and actuarial studies, and showed that they can lose up to $166 billion over 8 years, and that's a lot of money. And then not only that, the national deficit would also be added on to. In terms of Trump care in Ohio, fortunately it did not pass, but what would have happened if it did? 964,000 Ohioans will lose coverage. In terms of spending of Medicaid and monies that come in from the federal government, we would lose up to $48 billion, $535 million, lots and lots of dollars. Let's just put it that way. And the moderate and poor families are the hardest hit. Why? Because those are the people that benefited from the subsidies. Over 80% of people that bought health insurance on the marketplace benefited from subsidies. 644,000 Ohioans will lose Medicaid coverage, and nationwide, 11 million Americans. So one way to if you wanted to destabilize the healthcare system under Obamacare, the marketplace, one way is to essentially take away the subsidies. So that's what the AHCA was meant to do. No more subsidies. They take away the mandate that is in every single healthcare systems around the world, any sort of civilized, industrialized country. You have to have participation from across the entire country, across the entire population. That was going to be removed. No more mandate, no more individual mandate, no more employer's mandate. No more community rating. And that, the effect of that will send Obamacare in a spiral, a death spiral. It's essentially a plan to cut tax for the rich. For the super rich, $50,000 a year or so, and all of the taxes on pharmaceutical companies, on insurers, on medical device manufacturers will be removed completely. So if you know that 2/3 of the revenues to finance Obamacare came from that source of revenues, but if you took it away, what would happen? No more money to support the ACA, and that means that the ACA would have been no longer budget neutral. And across the board, liberals, conservatives, doctors, hospitals, patients, only 17% of Americans support the repeal. Trump Care would essentially block grant Medicaid. And the phenomenon of block granting Medicaid is that currently under the Medicaid system that we have now is that the federal government will look at the cost of Medicaid, the cost of it, the number of enrollees, and then the percentage of whatever the federal government contributes will increase accordingly if you have more enrollees, if the cost of Medicaid has gone up. If you block grant it, that means that you use 2016 as a baseline per capita. You give this much. What happens the next year, the following year, if the price or the cost of Medicaid goes up much faster? Let's say, for example, according to the Consumer Price Index, or according to the medical Consumer Price Index, or the cost of drug, whatever, we would be behind. They would be behind, and none of these monies will be efficient. And with the biggest population in Medicaid is children, right? And so the children will first suffer the most. Children's hospitals will suffer the most. They would also take away the pre-existing conditions. So, are they trying now to kind of like walk back a little bit? We may make it optional for states. So guess what? Most states will say, heck, we're going to take it away because we're going to let the insurance companies go back to good old days of discriminating patients. So when you say optional, that's just code word for, we'll just let them do whatever they want. And that will bring back high-risk pools. And we've learned that. We've seen that happen. Or high-risk pools, someone in the audience the other day said it should be named as high-death pools. Because under high-risk pools, essentially the premiums will be so much higher because they make those patients pay so much higher compared to the healthier patient. They make the deductibles much higher, up to like $25,000. How can you have $25,000 of deductible before the insurance company's payment kicks in? The wait line to get on this high-risk pools very, very long. This is why it's not by accident that the high-risk pools went away. This is why the Affordable Care Act or Obamacare was designed just to replace high-risk pools. Health savings account is a joke. You cannot reform a healthcare system with just health savings accounts. It's ridiculous. And then the tax credits are so small, and they're based on age and not based on income. So that's also financially, economically, and academically, it's a stupid idea. So block granting per capita per head, instead of just letting let's say a state goes into a tailspin in terms of economy, and then suddenly more and more people are qualified for Medicaid. You should be able to cover those. And when people say it gives the states liberty and freedom and flexibility to do as they please, what are those words code for? They're code for we don't give a whatever the word is about the patients. So you just go ahead and do whatever you do. It will hurt rural America because Medicaid is a big deal in the rural areas, and it will hurt children's hospitals. Talked about high-risk pools. Some of the biggest companies, biggest plans, the health plan of Minneapolis, health plan of Minnesota, high-risk pool of California. Deductibles are out of control. They've been labeled as monumental failures, inefficient and inhumane, and they're not an answer for pre-existing condition. We talked about health savings account. Only the rich can max out, and it's a tax shelter for the rich. Refundable tax credits, we talked about that. So what Trump Care also did immediately, would have done immediately, was take away two major taxes for Medicare. One is the hospital insurance tax, and the other one is the Medicare tax on the earned income. And those, they apply to only very, very rich people, like if you make over $300 million a year. So the high income earners pay those taxes, like 400 of those income earners. Well, under Trump Care, that will be completely removed. And so that added up to $2.8 billion per year would be removed from the tax revenues. And that calculates out to about $7 million per earner. In comparison, for the 160 million Americans making less than $200,000, zero tax cut. And then worse, for the 7 million Americans with the middle and low income Americans, by virtue of removing the tax subsidies, they actually will lose. They will lose on average by $4,800 per person. So actually they would be paying taxes compared to the high income earners. So I call it a great, great plan, blatant and immoral and spectacular plan to take money out of the ACA and essentially give it back to the rich income earners. And that would have happened first day if Trump Care had passed. The former Tea Party member, Tea Party is now, they're referred to as the House Freedom Caucus, and part of the big debate between the Freedom Caucus members, 30 or so of them, and Donald Trump was they wanted the 10 essential health benefits to be removed. Do you remember those crappy plans that were done away? And then they said, you know, if you like your plan, you can keep it, but then, you know, and about the 3 or 4 million people that fell into that category were like all up in arms. So, well, my crappy plans went away, so you lie. President Obama lied. Well, actually, they were paying for these so crappy plans that that the insurance companies who had a choice to grandfather them in, yet they eliminated them because they were so crappy, and then therefore their new plans under Obamacare would cost more just because they would cover more. Well, those 10 essential health benefits, the Freedom Caucus wanted to have them removed, but they didn't get removed. So that's why they had this rebellious vote no, leaning no, and this is why the AHCA or Trump Care never got into the ring. So Obamacare took over 60 repeal punches, and yet it stood tall and proud. And Trump Care or HCA did not even get into the ring and got KO'd right away. So for good reasons, and those are reasons that's why only 17% of people actually approve of that. So this is just a graph because, I'm sorry, this is the only graph I have compared to your graph, your talk. But look at on the left-hand side is that $2.8 billion would have been saved for the high-income earners, and that in itself is about equal to $2.7 billion worth of premium credits that would benefit over 800 million people? Yeah, in 20 states, in 20 small states, plus Washington D.C. So, so instead of money going to those individuals, that money would have gone back to those super rich people. So that's a complete blatant plan, essentially, to gut the ACA and then give the money back to the rich. So, and that's why it didn't pass. So, where do we go from here? And there are plans to revive. So I wrote an op-ed piece and I said Trump Care was knocked out before he got into the ring. But, you know, I can imagine the counting, you know, 1, 2, 3, 8, 9, and then now we have some inside information that maybe that Trump care is standing back up and it has been not completely knocked out. And I hope it stays down, knocked out forever, and maybe it will, but that doesn't stop some of these people to try to revive it. And so there's talk about maybe making the pre-existing condition provision optional, and that's very, very attractive to insurance companies. And removing the 10 essential health benefits, that's very, very attractive to the Freedom Caucus, but that would also make it a lot harder for moderate and responsible, some of the more moderate folks in the Senate, and that would also perhaps make them not vote for it. But who knows? Who knows? I think that it suffices to say that Obamacare is not perfect, got lots and lots of warts, but I think we should fix it. In fact, the most recent Gallup survey says that 67, almost 70% of people, Democrats and Republicans, are in favor, want to tell Congress to fix Obamacare and not to do away with Obamacare. So that's good news. I'll stop here. Thank you.
Our final speaker, and then we're going to have some back and forth discussion about what SPAN's role in all this is and where we move forward from here, is Deb Silverstein. She's our SPAN State Director for the last 6 years. Last 6 years? No, 4 years. 4 years, I'm sorry. But before that, she's a veteran teacher of 30 years from the Stowe Monroe Falls City School District. She was also served in various capacities in her local teachers association and was in active bargaining and grievance processing. She became active in SPAN in 2008 as a local leader, and then became our state director apparently very quickly after that. And here's Deb Silverstein.
First of all, thank you for coming today. It's really nice to see all of you here, and I appreciate it because this is the work session, and I'm going to expect a lot out of you guys. Okay, I'm not a doctor. I'm the retired school marm. Probably got this position because school teachers do have great managerial skills. You have to in order to survive a classroom. 30 teenagers at 7:30 in the morning is kind of on the cruel and unusual side of things and stuff, but we managed to do it, and we managed to enjoy it, and some of us have a hard time leaving, at the end. So it was a great career, but this is something that's new and exciting. Since I'm not the doctor, I'm the patient. I'm the one that this healthcare system is supposed to be about, and I'm the one it doesn't work for at all. I do have insurance. I've got insurance through State Teachers Retirement System. It's crappy insurance. The deductible when I was working was $100 a year. When I first retired, it was $500 a year. Now it's $2,500 a year, plus the 20% co-insurance for an out-of-pocket of $4,000 something a year, plus what they won't pay for and all of that other, and the co-pays and stuff. It adds up pretty quickly. Last December, I broke my hip. I didn't plan to break my hip. I certainly wouldn't have done it if it had been a choice situation. Unlike what the anesthesiologist thought, she thought I should have planned to break my hip where I had in-network providers. I said, well, I wouldn't be needing your services. I'd be needing the psychiatrist if I had planned to break my hip and that. But at the time that I had broken it, I had met that $2,500 deductible. I'd already paid that much out. So when I broke it, I had no choice of ambulance service. I had no choice of hospital. The one I was taken to was the only one in town. I had no choice of ER doctor. I had no choice of surgeon, although I tried to. When they told me who my surgeon was, I said, that's very nice, but she better be in my network, otherwise keep looking. They went out, they checked, came back and said, she's in your network. No, she wasn't. I had no choice of anesthesiologist, no choice of radiologist, no choice of hospitalist that was assigned to my care. Even though the hospital was in network, not a single one of those providers was. Not one. Most of them work for a company called Mid-Michigan Physicians Group, which is a wholly owned subsidiary of the in-network hospital. So was the ambulance service, a wholly owned subsidiary of the hospital, but it was not in-network. And then the hospital would say, well, we can't force them to be in-network. You own them, you certainly can too. And so we get into what's known as medical bait and switch, which is even more disgusting than when it occurs on a car lot. Because on a car lot, you can walk away. But when you're on a gurney in the ER with a broken hip, you're not going anywhere. You're stuck. You are their victim. And you're going to pay their rates. And as I explained to that anesthesiologist, she says, well, there's nothing I can do. It's the company I work for. I said, well, when they send me that outrageous bill, it's not going to be the board members' names on it. It's going to be your name that's on it. You're the one that's going to be the greedy, you know what. I said, now if that's okay with you, carry on. I said, if it isn't, you find a way to make them know that this is unacceptable to you. The problem is, most of those physicians did not know they were out of network. Because they belong, most of them, they have their practices, but they're hospital-owned practices, and that practice has their own board that makes all those decisions. Most of them don't know. The problem with our system, and the problem that Obamacare, the ACA, however you refer to it, creates, is that we still rely on a market-based, for-profit system for healthcare. Healthcare doesn't fit that model. In a for-profit, market-based system, the consumer is the king. The consumer has to be able to walk away. You can't do that with healthcare. Consumers Union, which is an arm of Consumer Reports, you've heard of that, they estimate that only 7% of healthcare is actually shoppable. And yet we are insistent upon putting this square peg in the round hole and telling people you need to be a better consumer of healthcare. As the anesthesiologist said, you needed to plan your hip fracture better and stuff. So this is where we are with a market-based system that is not a market-based commodity. Okay, so where are we in Ohio? We did expand Medicaid, and that was a good thing. There have been some good things that have. Are we okay? No. That have happened because of that. And many people like being able to keep their kids on their insurance until age 26 through age 26. Many, the ban against pre-existing conditions is a good one. That's the only way my sister got coverage. No one would sell to her before because she had a history of abnormal pap smears and cysts in the breast. They didn't want to take chances with her. Okay, it's the only way my girlfriend got insurance. She had a prescription for metformin for pre-diabetes. They were not interested in insuring someone with pre-diabetes. So, those were the things. That was a good thing when they made them do the guaranteed issue. Problem is the insurance companies learned how to work around that. They didn't want to insure HIV patients. Well, then they knocked the HIV drugs off their formularies. They don't want cancer patients. They don't cover the cancer drugs. They'll issue them a policy. They're just not going to pay for their care because it's not part of their contract. And that's how they get people. Again, this is not a market-based commodity. And the other part of it, when we talk about the 27,000 that died, and most of us say that's sad, but people die. Well, I met the mother of one of those 27,000. Her daughter injured her leg. A few days later, she had a terrible, terrible pain in her leg. She was between jobs. She was uninsured. She went to the ER because the pain was so bad. They told her, this isn't a doctor's office. Go get insurance and go see your doctor. 2 days later, she was in the ICU, and she died of a pulmonary embolism. That was a blood clot that was causing the pain that they didn't even check for. There's my friend Marty, who was diagnosed with terminal cancer. She had employers-based insurance. As she was dying, at first she would go to work because she wanted some normalcy in her work, in her life. But then she was dragging herself into work as often as she possibly could to maintain her insurance coverage so she wouldn't bankrupt her family while she was dying. You know, this system, it's not just a financial bankruptcy that we've caused, it's a spiritual bankruptcy that we have caused. Because you are not a human being in need of care. You are first a revenue source. And you better prove that you can provide that revenue. Have you heard of the Cleveland Clinic? I called there one time. I had had a headache that had gone on for 6 weeks. I couldn't sit up or stand up because of extreme pain. And when I called them to their headache clinic, I started to explain that, and they interrupted about, did I have insurance? So once I proved I had insurance and that would cover me at their place, then they asked about my symptoms, and then they got all excited because my symptoms were severe and they needed to get me in right now. You need to get here now. Yeah, I was trying to tell you that, but you wanted to know you get paid first. You know, we're revenue sources first. So, okay, we expanded Medicaid. We're back to where we are because the slide's back up. Ohio Department of Insurance is supposed to be working for you, and insurance companies submit their increases to them, and they are supposed to investigate and make sure that those increases are actually warranted. But they don't. They just rubber stamp, okay, you submitted the paperwork correctly, go ahead, and that's the way it is. Healthcare costs in Ohio are higher, and our health outcomes are poor in this state. We have communities in this state where we have infant mortality rates that are greater than third world nations. One of them is about a mile away from the Cleveland Clinic. It's the community of Huff. It's a poor community, minority community, and the Cleveland Clinic's not real interested in that. Although all lives deserve world-class care. So, SPAN Ohio is the only organization that's working to achieve a Medicare for all type healthcare system here in the state of Ohio. There are other organizations that are working to improve healthcare access, to do incremental steps, to implement the ACA fully, to protect the ACA, and that type of thing. We are working to change, make fundamental change to our healthcare system because we believe that's what it's going to take. That the way we are doing it right now will always leave people out. And how do you make the decision of who you leave out? Who are you going to leave out? Are you going to leave out him? Can we leave out your daughter? I mean, it's left out my sister in the past and my brother in the past. So if my siblings can be left out, can yours? When it comes right down to it, we can't make those choices. Okay? So we need a fundamental change. We need to change a healthcare system so that it works for the patients. And we need to take Wall Street out of the mix. We want a healthcare system that meets human rights standards, and those standards are, first of all, true universality. Everybody in. Where the criteria is, are you a human being? Do you live here? Okay? Are you a human being? Do you live here? And notice I'm not asking, are you a citizen? Human rights doesn't ask that. Okay? There needs to be equity. You know, equality is, well, she didn't have open heart surgery, so you can't have it either, but she had a colonoscopy, so we'll give you that. Well, Maybe you don't need the colonoscopy. Maybe what you need is the heart surgery. Equity is where you get the resources and services are distributed to meet the needs of the patient, not the needs of the bean counters. Okay? So you get what you need, she gets what she needs, he gets what he needs, based on need. And those services have to be equitably distributed so that the people in Vinton County and Meigs County aren't driving an hour and a half to see a primary care physician. Okay? It needs to be transparent. We need to be able to see and get the information on how decisions are made. It needs to provide useful, meaningful participation by the public at all levels. You know, public participation isn't just that you sit down and have a nice chit-chat with your doctor. Public participation means that the public has a say in how this system is run at all levels. And then this system has to be totally accountable to you and me. Right now, it's accountable to Wall Street shareholders. Now, when we talk about the insurance companies, they're doing what a for-profit company should do. They're fulfilling their responsibility. Their responsibility isn't to us, it's to their shareholders. They have to return a dividend and a profit, and they have to show growth. That's what for-profit is. When Mylan raised the price of the EpiPens, they were doing what a for-profit company should do. The problem is the way we have created the system. Okay. Now, how do we go about creating that system? Do we do state level or do we do national? And SPAN has always been adaptable to both. We take whichever one comes first, whichever one we could get. There are some people who think the only way to get a national system is to have the states do it first. And history tells us that's probably true. That's how most social changes have come about. Things like public schools, even Social Security, the women's right to vote, and so forth. But there's always the part that says never say never. If there's an opening and we could do it nationally, then go for it, and we fight like the dickens to get it. Okay. If not, then yeah, we fight at the state level. And we do have a bill at the state level. We have Senate Bill 91, and it creates as close to a single payer system as you can possibly get at the state level. Okay, we can't include Medicare, that takes an act of Congress. We need a waiver for Medicaid, but we can probably get that fairly easily. We need ERISA waivers for employer-sponsored insurance, and those are a little more difficult to get. They're not totally impossible to get. Hawaii got one, and if we follow their example, we might be able to get that to make it a better system. Our bill, however, is not getting traction from legislators despite our lobbying on it. And the other thing is when you go legislatively, it's subject to amendment and it could end up being a very foreign object by the time they finish with that. That would be a problem that we would have and that we would have to fight to prevent that from happening. Because right now it is that true universal and they always want to exclude somebody. Although that makes it more expensive because you have to have gatekeepers. The other way to go about it here in Ohio is through a ballot initiative. And that, it would need to be a constitutional amendment because we have to override the Healthcare Freedom Amendment, which we passed in 2011. The Healthcare Freedom Amendment basically does not allow the state to do anything in the realm of healthcare. They dotted their I's and crossed their T's, but what we need to do is replace that. It was specifically designed to fight Obamacare, although it didn't work on that level, but also to prevent us from doing single payer, so we have to come in and replace it with a single payer plan. So we could do that, though. We could do a constitutional amendment. That would require massive numbers of volunteers to get signatures. We can do that. When we want to, we can do that. If we're serious about this, we can do that. Okay? But we also need to build a large war chest to conduct a campaign. How many of you heard of Colorado Care? Okay. That was an initiative in Colorado to create a healthcare cooperative, which would have been close to single payer, along the same lines there. It was defeated 80%, 20%. They were outspent 8-1 by large insurance companies and outside groups. The money they had collected was all from individual donors. Span Ohio gave them some money, and then individuals sent them money. The problem with a lot of those ballot initiatives is they are severely underfunded. Okay? We won't go that route until we know we have the war chest we need in order to fund an adequate campaign. Now, you will be pleased to note that Anthem Blue Cross Blue Shield of Ohio was one of the largest contributors to the campaign against Colorado Care. Okay? So, yeah. Well, $500,000 is what they said. Your premium dollars at work. So there's a gentleman here in Dayton who wrote during the campaign 100 letters to Hillary Clinton about health care. Remember, Hillary said single payer never, ever, ever, ever on my watch. Well, he decided to give her a little education on the issue. And he is constantly talking about the 29% increase that he got from Anthem Blue Cross Blue Shield. And I told him, I said, you don't understand. I said they needed that increase because they were the biggest contributor to the opposition of Colorado Care. I said, and the CEO couldn't handle that kind of a cut, to fund that. And so it has to come from you. And he says, I thought because of my pre-existing conditions, was single-handedly bankrupting Blue Cross Blue Shield. I said, no, it was not you. So what I want to know from you guys, before we could even attempt something like this, is some of the answers to these questions. Okay? I need this information from you. What do you view as the strengths of Span Ohio? First of all, how many of you were familiar with Span Ohio before you came to this event? Okay, quite a few of you. Okay, and those of you that weren't familiar, this is your first time coming to something. This is the first time you've heard of us. And how did you hear of us? Okay, from Bill? Yeah? How many? Facebook? Facebook? And the campaign for guaranteed health care, which our brothers from Indiana, from IBT, they were a part of the founders of the campaign for guaranteed health care, as was Span Ohio. And we're working nationally. That's a national coalition working for Medicare for all, single payer. How many of you are familiar with single payer, the term single payer? Okay. Y'all are? Yeah. And basically, guys, single payer is just a financing scheme. It's how we finance healthcare. It's a streamlined approach. It's what we're saying when we go single payer is we're saying, okay, there's some things that we can do on our own, and there's some things that we're going to do collectively. Healthcare is not something we can finance on our own. Healthcare is something we need to finance collectively. And so single payer, we all pay in to the same commodity and they pay out. Instead of we pay into 1,000 different areas and 1,000 different payers pay out and that type of thing. Okay, what are the weaknesses? How familiar are you with Span Ohio's messaging and how effective is it? And what would make you become active with Span Ohio? Okay, and so I've got my note takers. Okay, Span Ohio strengths. Let's start there. And let's hear from you guys. And we can come down there and...
Okay, hi, I'm Elizabeth. I recently got involved in the local SPAN chapter, and just listening to the four of you guys present, I feel like we have like a strong both academic basis for the single payer kind of SPANs project, and also like the emotional basis, which I think is super key, because I think if you go one way or you go the other way, sometimes it's not. It's that balance of both, because you appeal to the heartstrings, but then you kind of actually rope them in, because to actually get policy change, you have to have the academic support, which I feel like we do. So like, just that overall presentation and our backing is really strong. So.
Thank you. Yeah. Who else? Yes.
Hi, I'm Tana. I think, well, I don't think I've ever met one person that hasn't complained about insurance. So, I mean, everybody in the country hates something about their insurance, so I think that's a strength right there. I mean, like, I just found out my insurance for my company is going to take Miami Valley Hospital out of our network. What the heck? I mean, I'm about ready, because I come into events like this, to go around at work with a roster and have people sign to take it to my bosses, because it's crazy. But I think just like everything you just said up there, and if we just put a couple more messages in that touch on all the things that happen to people, I mean, everybody can say, yeah, that's right, that happened to me, you know?
Okay, thank you. Who else has a comment? Okay. Weakness, yes.
I was just going to say, I think this is a good time to go for broke, because healthcare is at the forefront of everybody's minds with all the stuff that's been going on lately. The Congress doesn't hesitate to point up any flaw in the ACA. And I think, well, okay, let's put your money where your mouth is, and let's fix it. Let's fix it right, so that we get rid of the insurance companies. Now, I know, that's going to take a lot of doing, because they don't have any moral courage. But I think this is a perfect time to push for it, because that's the only thing that's really going to fix the problems and make sure that everybody keeps, coverage.
You're right. They don't have the moral courage or the backbone that they need in order to get this job done. And it's up to us to provide them with that. And we did do that. You guys did that when the American Health Care Act was up. And that's why it was withdrawn. It was withdrawn. I mean, the calls into Washington, D.C., into their offices, the phones were ringing off the hook. You guys did such a wonderful job with that. There was an analysis done that they said that for every 1,000 calls in against it, there was only one that was for it. When you guys showed up at town hall meetings and your representatives were scared to death, or the ones were scared to death to even have one and wouldn't come because of what had happened, that was you guys that did that. The power does rest with us when we choose to use it, when we choose to exercise it. We need to band together, and we need to exercise our power.
I have a question. I wondered, are there any states that have single pay, and are they successful? And secondly, how does KSIC feel about single pay in Ohio, or are there any representatives who support this?
Okay. There are no states that have passed it yet. There are states that have come close. Vermont passed the bill, but the governor chose not to implement it. And he's not there anymore. Hawaii actually had a bill passed, and that they've had administrations that have chosen not to implement it. And both of those, it may be that their market is too small. In Vermont, their population is, a low one. It's less than 1 million people there, and health costs are high. They may not be the best one. They may need to band together with another small state. New York is getting close to passing it. They have passed it through their General Assembly, their lower assembly, twice now, and now they're working on getting it passed through the Senate and to the governor's desk. So they are really making some moves. California is on the march. They're going to do a ballot initiative if it doesn't go through the legislature. They've passed it twice through the legislature, and it was vetoed by Arnold. Oregon and Washington State are on the move. Both of them would like to do ballot initiatives in 2020. And we kind of would too, if we've got the support of the people and the people working with us to get that done. Okay? So no one yet in the states. There's plenty of other countries that have done it successfully, in various forms of it. Okay? Not all countries with universal health care use a single payer plan, but Canada does. Britain takes it a step farther. They have a national health plan system, and it's true socialized medicine like the VA is, where it is not just financed by the government, but the hospitals are owned by the government and the doctors and employees are government employees. And some people are afraid of that, but the VA, when funded properly, and considering the clientele that they take care of, they've had some excellent results that have come out. And that VA study that Dr. NJ referred to was a real critical one, showing that quality care, we can erase all of those inequities in healthcare if we give true quality care to everybody. And for too long we thought some of the disparities were due to racial differences. They're not. They're due to differences in the care people get. And that's what has to change.
Can I just add in something quick? Apropos to the question of whether other states have it, the Canadian system, actually, people don't realize, although it's a system across their country now, it actually started out as a province-by-province system. So it went from one province and then ended up spreading to the rest of the provinces over time. And that's kind of the model that we're looking at here in the U.S. too, is if we can do something as a state-by-state thing, it can spread after that.
Yep. The most revered Canadian is a man named Tommy Douglas. And he's the one that got it passed in the first province in Saskatchewan. And there's a good movie called The Healthcare Movie that talks about how Canada got their healthcare system and the work that Tommy Douglas did. And it's narrated by Kiefer Sutherland, Tommy Douglas's grandson. So, and that. Congressional support for the national bill, H.R. 676, which is in the House. It's introduced every session by John Conyers of Michigan. Has 94 co-sponsors right now. From Ohio, we have all 4 Democrats have signed on as co-sponsors. And this is early in the game to get them to do it. Usually Joyce Beatty and Marcy Kaptur do it right away. Tim Ryan after we bug them a little bit, and Marcia Fudge has been elusive, but she has signed on this time. So we've got all of ours. 94 co-sponsors is more than what the bill has had since the ACA was passed. Okay, so we're gaining steam on that one. Bernie Sanders is going to be introducing a single-payer plan in the Senate, and we need to really work to get Sherrod Brown to be a co-sponsor of it. He has not in the past. Here in Ohio for Senate Bill 91, which we picked up a co-sponsor this year. We have Mike Skindle and Charlita Taveras have introduced the bill. They are the joint sponsors, and co-sponsors are Cecil Thomas, Sandra Williams, Edna Brown, Vernon Sykes, and there's another one that I'm not remembering right now. Kenny Yuko. So we're up on the number there. We didn't have it introduced into the House last session because those that did introduce it in the past had been retired due to term limits, and no one else was willing to pick it up, but we're pretty sure we've got somebody who's willing to pick it up at this point and introduce it into the House. So more interest there when you've got people that are willing to do that for you and stick their neck out. And people have said the whole situation has changed. And yes, I'm coming on board. So I think you're right. I think this is the time to really make hay on this issue.
Deb?
The governor, well, he actually, it's kind of hard to tell what he thinks sometimes on these issues. When we were doing the Medicaid expansion, we went to a rally in the State House that he wanted to have. He called it a forum, but it was really a rally. And he gave a real good argument for single payer, and stuff. But when we approached him on it, he said, well, talk to Greg Moody, and Greg Moody just said, good luck with that one. So I wouldn't expect Kasich to really be supportive of it. Now, of those that are running, Josh Mandel, no, he's not going to support it. And part of what we're up against, it's total ideology. It has nothing to do with creating a healthcare system that meets the needs of you and me. It's total ideology. On one side you've got the market ideologists, in the middle you've got the incrementalists, and then over here you've got the single payer people. And even further, the human rights people. That's, I consider, because not everyone takes that into account.
Tim has a question.
Yeah.
I know that SPAN, Deb, is planning an initiative
Yes.
for 2020. Could you say something about that, please?
Well, we would like to do an initiative, and it would be pretty much what's in House Bill or Senate Bill 91, which would create as close to a single-payer system as possible. We want to put a little more into it to connect community health efforts, public health efforts, and clinical care. You know, because we need to work on some of the things besides just medical care. We need to take a look at some of those social determinants of health, because they are going to affect how much we are spending on health care. Once we get universal medical care for everyone, then the drivers of costs are going to be those social determinants of health. And quite frankly, health follows wealth. We need to do things to help bring people up. We've got to start creating jobs in the state of Ohio that provide living wages. You know, we aren't doing that. The last time we looked, you know, we analyzed it, the top 10 jobs being produced, only one provided a living wage. None of the others did. It was all minimum wage. We need to look at environmental concerns. We need to look at nutritional concerns. We need to look at education. All of those things go in together to create health. Okay? So health care is all of that stuff.
I'm going to go back to your key goals, the key goals today. We really wanted to get some organizational representatives here today too, and I know there are some. So it really is important. I've seen so much collaboration the last 2 months amongst organizations who previously were kind of very distant from each other. And we do have these overlapping goals, and we've come together for several events the last couple months to work towards those goals. And I think it's great, and I want to continue that movement. So basically, if any of those representatives have ideas as to, again, what do you view as the strengths or weaknesses of SPAN Ohio, particularly, and how familiar are you with our messaging, and how can we get you to, again, collaborate with us and us collaborate with you on the things we do overlap on, and to continue to grow our coalition here in Ohio.
Yeah, and we really do need that information, because that's going to determine, you know, the path we take to get ready to do that ballot initiative in 2020. We have to do the homework first. We have to build that base. We have to have the support, and we need to be able to communicate effectively with the voters. So we need to work on that. Okay.
Hi. First of all, Deb, I had 3 kids that graduated from Stoneman Row Falls High School.
You did?
Yes, I moved here back in June after my last one graduated. But on to, I am involved in a couple different organizations, and I think that's one of our strong things. I also think it's one of our weaknesses, because we are really struggling. I have to leave because I'm going to another meeting. I mean, right now, we have so many things that are important to us, and we have to figure out how to make it all work at one time.
Right.
And that's the whole, you know, what's going on. And I just think that's something we have to work at, because, you know, this room should be full. And some very important information was provided here and I've been to multiple speeches of you guys, and I still heard more stuff today. This subject is, and all of these subjects are so much more complex than I don't know, I've always had employer provided health insurance. If you go to single payer, how, you know, where does the money that they're spending, how do we get those companies to contribute, because it would save them money, but how do we get them to contribute? I mean, there's just so much to all this, and so I think so much is we just have to coordinate all of our efforts, because one of the reasons this room isn't full is because there's like 5 other activities going on right now.
And you know, and that is an issue, that there's so much that we have to be aware of and involved with, and that type of thing. And that's one of the reasons why we have to come together, we have to support each other, all these different groups. And there are connections to all of them. And so, you know, I could go out to an environmental action and wear my t-shirt, healthcare is a human right, because anything that an environmental group does affects health. You know, I can go to something with the food banks and that affects health. I can go to a minimum wage rally, that affects health, and I've been to all of those things. So those things, we all need to vow that we're going to work together and do that, and that's where that will come from.
And we also have to really work on the educational component of
Absolutely.
this, because again, I think in general, and I may be wrong, but so many voters, you know, people that actually go to the polls do have get their insurance from their employer.
Mm-hmm.
And until they have a major health plan or problem, they really have no idea how little their insurance covers.
Right.
You
And,
know, I mean, it seems like when your kid breaks their arm, you go to the hospital. You know, it costs you a couple $100s, but it's not that big of a deal. It's not until your father has cancer and he's not Medicare eligible yet, or or you end up with a kid who has an opiate addiction, or any of those other things, that you realize how little insurance actually covers.
You know, and it doesn't have to be anything that is catastrophic. This hip, and I had paid my deductible, keep in mind, I had met my deductible already, but it is still costing me out of pocket over 2 months' income. Most Americans can't do that. And I keep holding them off. Some of them are going to send me to collections eventually, but you know, that's the way it works. You know, and medical debt's the biggest reason for collections, only in America. This is American individualism.
Yeah, I think what we
and
didn't
that-
point out with the bankruptcy stuff is there's no other developed country in the world that has any bankruptcies or any deaths due to uninsurance. But anyway.
Yeah, we're pretty cruel to
What
one
I was
another.
going to say is I agree with you. I think the education thing is so key. You know, I get lost because this is what I live in every day and see every day. So I forget sometimes, you know, my perspective is not most people's perspective on healthcare. But also I feel like if I could just talk to everybody in Ohio, we would have healthcare tomorrow, right? Like there's no way that people, like, you know, we were up in at the Miami County Fair just last summer talking to people, and it doesn't matter what part of the political spectrum you come from. Like somebody mentioned earlier, everyone hates health insurance companies. They're a disaster. And all you have to do is talk about the savings, talk about the people, and really we can. But it's exactly as you say. How do you get everybody to come? How do you get all of these seats filled? Is the important thing. Don wanted to say something.
What do you want out of the healthcare system? Most of us want to know it's going to be there when we need it, right? And we want it to be high quality. Because we want the best for us and our loved ones when our life is dependent upon it. But we really don't want it if we don't need it.
Yeah,
You know,
yeah.
that type of thing.
Sure.
We've got somebody right here.
Wendy, I think you're absolutely right, and that's really too bad today because one of the reasons Lynn is not here is that because she's at another place, and then there are like 5 things going on. I was not aware of that fact, but you're right. This room should have been packed, just like at Clyde Elementary School event that we had. You say that, well, you know, it's not a big deal to a lot of people unless it happens to them, and even then it's, you know, maybe a couple of $100 here and there, and it's right. So this is the issue back in 2008, 2009 when the debate happened, because the individual market was just a very small portion of the whole healthcare system. Employer base of the large market group was about maybe 60% of the whole population, right? And then the rest of them are like VA and Medicare and that sort of thing, and Medicaid. But so the individual market was very small. And that's why we faced with questions like, I have health insurance, I have it pretty good, I don't know what you're talking about. Who are these 40,000 people that died we never heard of, we never see? And this is why the messaging was so hard to try to get through the American psyche that, yes, you may have employer-based insurance, but the other people have really bad. The pre-existing conditions were weeding people out, and millions and millions of people were being left out, and insurance companies were basically making billions and billions of dollars in savings by not taking care of people with very ill, very severe sicknesses. So what is happening here, however, with the employer-based market is that the high deductible plans are now affecting them. And so when you hear about people that go into bankruptcy because of medical emergencies is still happening. And then worse than that, CEOs and owners of companies sitting there looking at their employees in the eyes and say, I'm so freaking sorry that I chose this plan for you, but this plan is really killing you. And this is why we see, for example, companies now moving to places like Canada. What's so great about Canada? They have universal health care. So their employees can be covered by Canada. And then as a CEO and owner of a major corporation, these people have much clearer conscience and much better dealing with their employees, and then they can concentrate on making their employees happy and compensating them, because this huge weight of being responsible for their health insurance is now relieved, because now they're living in Canada. So it's happening now to even the large market. So don't be, if you really are like really cynical, you want to see this huge big explosion of horrible things that happen to the employer base, and then and just like the frog that's been sitting in this little beaker that is now boiling slowly, and you crank it up the heat, and then now the frog has to jump because the temperature is so high. This is what I think some people are saying, that we've gotten to this boiling point now that something has got to be done. Just want to throw one more thing to there. So you do this single pay thing at the small level, the state level, or the big level, the federal level, or whatever. I just want everyone to remember that maybe the public option should be back in play. And the public option, you remember there were lots and lots of constituencies that worked really hard to defeat that. The hospital systems, the pharmaceutical companies, the medical device manufacturers or whatever, they saw this, they had this vision of this hand, a federal hand that was grabbing, that was going over this public option and controlling everything. And this is why they worked really hard to defeat the public option. But if you bring it back and you still have the other marketplaces of other insurance plans to compete with, then it's now free competition. And maybe the public option has a better chance to succeed this time around. And then the public option will just be maybe an extension of the single pay as time goes by. So that's something to keep in mind.
Her question was, how do we make the companies pay? Most single-payer bills do have tax provisions for raising revenue. At the state level, with the studies that have been done, and we have commissioned an economic impact study for Ohio, they're recommending 10% payroll for businesses, 3% individual income. And for most of us, 3%, I did the math for me, and 3% is much less than what I'm paying now. 10% payroll for businesses is much less than most of them are. A few years back, I did the numbers for schools, and they were paying an average of 21% of payroll at that time. So it would be a huge savings to them.
I was in to see my doctor this week, and I have a really good relationship with him, and we talk about a little bit of everything. And I asked him about Doctors for America, and he didn't know what it was. Mm-hmm. I asked him about Span, Ohio, and he didn't know what it was. He does now. Uh-huh. But, but that, it really concerned me, because we have to educate them too.
Yes.
And,
yes.
Where do we start with that?
Yeah. And you know what? Get one of those brochures for Physicians for a National Health Plan and take that to them and tell them, you need to look into this group here. And I did that with my dad's doctor, and he wrote me a note and thanked me for it, because he went to the website and looked it up, and he wrote and thanked me and stuff. But, so let's get back to my questions if we can, and we can still answer some and that type of thing. Let's move on to weaknesses of Span, Ohio.
I have a question, because I collected any petitions before the ACA came along, and we got our percentage of petitions or signatures that we needed in this region.
Yeah.
And I assume this initiative would have to do the same thing. It would be,
Yes.
we have to get a certain percentage in different regions.
Yeah.
And I think the big weakness back then was that like southeast Ohio, and we had nobody.
Actually, Southeast was pretty active. It was in
Was
the
it?
middle. It was northwest, outside of Toledo, in some of the rural counties that we had some problems collecting that. We just didn't have enough people. And that was the weakness that we had then. That's one that we're trying to correct. We're trying to correct that by bringing you guys on board in the hopes that you'll help. Okay? Is she coming back? She had a question. He had a question back there.
Make a statement. Basically, we need to keep in mind that the reason a lot of this room's not full, it might not be because everybody's at another activity or another demonstration, but there's a lot of people that have to work 2 or 3 jobs to even afford to be able to buy a gallon of milk for their kids.
Yeah.
That's why that's why a lot of people aren't here. It's not necessarily that they don't even have time to go to another activity.
Yeah.
It basically boils down to greed. Why a lot of things are not happening, and we just need to be active and fight it and do what we can. And everybody just stay strong. Like you said, you need to try to get more people for Ohio. If we had an activity that had been planned for Indiana, we'd be in Indiana today. You guys are the closest one, so we come over here.
And we're so happy to see you. Thank you for coming.
Uh,
And there is a single payer group in Indiana. Hoosiers for,
Hoosiers for Common Sense Healthcare,
yeah.
or a Common Sense Health
Yeah,
Program.
and I think it's run by an ER doctor out of
Bloomington.
Bloomington, yeah, Rob Stone.
Rob Stone, right.
So, all right. Okay. She's been anxious right here.
Well, I just want to say, does it usually fall along Republican versus Democratic lines?
Does it usually fall to Republican versus Democratic lines? Unfortunately, yes, except in a few rare instances. And she's next. Gal just coming right back in. In Pennsylvania, before Obama was elected, in Pennsylvania they had bipartisan support, and they were very close to getting it passed at that point in time because of their bipartisan support. And that was because the president of their group was a former Republican legislator and business owner who got involved with them, and he was able to get some of that bipartisan support because he went in and said it is good for business, and it's really a very conservative proposal fiscally, as far as cost goes. And so he got that bipartisan support. We have lobbied. We've never gotten a Republican to co-sponsor, but we have had some say, if it comes up for a secret vote, I'll vote yes, and that type of thing. So we've got, that's more than what they would say before, but there's some of them that know, and they're not being horribly vocal against us and that type of thing. And I will tell you, there's one, Scott Olslager, who he looked through it all. He says, we've got to get the Chamber of Commerce on board. And I said, I don't think we're going to do that because they sell insurance. That's really, that's how they do their overhead and that kind of thing. He goes, well then we have to get business on board, individual businesses. He didn't say you, he said we.
Just as a matter of point,
That's important, right back there. Go ahead.
there were 86 individual invitations were sent out to individual politicians from every party, not just Republican and Democrat, but every other party as well, plus city commissions throughout the 7 counties that are within Region 7, plus other healthcare organizations and other interest groups who may have any vested interest in helping with healthcare reform. So certainly SPAN is attempting to reach out across all spectrums and every political ideology and chambers of commerce and city commissions and everything like that. So they have been invited. We did make follow-up calls as well, and it's very difficult. We've had a lot of difficulty trying to reach out.
Well, how many of you have ever had a meeting with your state representative? Okay, there's where we've got some room. You can do that right here in Dayton. You don't have to go to Columbus. In fact, it's better if you do it right here in Dayton. You call their Columbus office and you tell them you would like to have an in-district meeting with them. And they will set it up for here in Dayton with you. And you can bring a small group along. Usually you have it in a coffee house or McDonald's or the library or someplace conducive to conversation, but public and that type of thing. And because they don't have the budget to have an office back here at home. So that's, a lot of them work out of libraries. Mine works out of the coffee house downtown. That's where I meet with her and that type of thing. But do that and talk to them about the issue, whether they're Republican or Democrat. We tend to go to the ones that we think will support us and we avoid the ones we don't, and we really need to be talking to everybody and give them all a chance, first of all, and educate those that are opposed, or at least let them know they're not representing you, your interests. Okay?
Yeah, I thought the example you gave with the ex-legislator in Pennsylvania was very instructive.
Mm-hmm.
This is about messaging, like your sign there. I agree with that totally. But what you're doing there is only reaching towards people's compassion, and some people cannot be reached by that.
Right.
What they want to know and what will make them decide is what's in it for me.
Mm-hmm.
Will it make will I get better care? Will I get a better deal?
Mm-hmm.
Because there's so many people out there who might have good employer insurance and they're healthy. And and then they hear about this Obamacare and they say, well, that's just about giving health care to poor people. There's nothing in it for me. And they don't consider that their factory may move to China or that they may get sick and not be able to work. So the messaging has to go at it from that perspective as well to reach people like that.
Mm-hmm. Thank you. That's good information. And yes, that does tend to speak to the choir. It doesn't necessarily speak to the non-singers and that type of thing. Yeah. And right. And that brings in the first group, okay? And then you've got to move beyond that to get out, to the non-singers and convince them that they can at least come to choir practice and mouth it, whatever. And stuff. I think one of the things that people need to realize at this point, we had the first attack on health care came with the American Health Care Act. And that was to repeal Obamacare, give a tax break to the millionaires and billionaires, and really throw the rest of us to the wolves. And that was their hatred of the ACA and their hatred of anything Obama. Okay, they have bigger plans than that. The Medicaid, they still want to turn into a block grant, and they may not get as big an opposition except for the hospitals, because that's going to affect revenue for the hospitals. If they did something like that. They want to turn it into a block grant, and with block grants, generally funding stays pretty level and it's not based on the need, and it becomes inadequate, and people get dropped and more people get dropped as time goes by, and eventually you do away with the program, and that's the goal. They're after employer-based insurance. Right now, you get those benefits. You're not taxed on the value of those benefits, the cost of those benefits. They want to change that. They want to tax you for those benefits because they think employer-based insurance is too generous and you need to have more skin in the game because they think you use too much health care. You're going to the doctor for frivolous reasons. So I should have laid on the kitchen floor until my hip healed. That type of thing. Totally unrealistic things. Now, I want you to know what we provide for them. Not just an insurance policy that's probably better than ours. Underneath the Capitol building is a clinic. that's run by the Office of the Attending Physician, who's a naval doctor. That clinic will do physicals, they'll do blood work, x-rays. If a member of Congress needs physical therapy, they'll bring in a physical therapist. If they need a urology consult, they'll set them up with a Navy urologist for free. Members of Congress pay under $600 a year for that service, and beyond that, it's free. In addition, there are also clinics in each of the office buildings that are staffed by a nurse that they can go to. Now, I know about that because I went to one of their clinics. And it was my congressman's office, Tim Ryan, who took me down because I had a horrendous headache. And the nurse, let me lay down and sleep it off, gave me some ibuprofen, checked my vitals, put an ice bag on my head and that type of thing. And she says to me, now you said Representative Ryan's office brought you down here? And I said, yeah. And she says, do you remember which one? Because we have two. And I said, oh, it was definitely Tim Ryan. I said, Paul would have kicked me to the curb and told me to get a job. And she says, yeah, that's pretty much the way it is.
We just have time for just a couple more questions.
Yeah.
Another comment?
Oh, it's okay. Go ahead.
Oh,
I'm sorry.
I just wanted to know what doctors are thinking of the single payer. Are doctors all doctors, okay with it that you know?
Not all of them. As you get closer to primary care, the support for single payer skyrockets. Among the specialties, it's not as high, but the primary care, the people that are on the front line, there is big support there. Now, overall support is increasing.
It's at about 60% across all level, any kind of doctor. If you poll all doctors, it's around 60%. But yeah, like Deb said, obviously 2 of the 3 of us up here are primary care docs. But if you look at ER, primary care, psychiatry, things like the family practice and the pediatricians tend to be much more for it because we see every day, what's going on with healthcare in this country. What happens with specialists is it gets filtered out a lot. You don't send people to specialists that don't take people's insurance, right? They just never see the people that are uninsured or that don't have good insurance. So you tend to get less, they tend to just see less of the problem, basically.
Right. What do I know about primary care? Right. I'm a urologist. So to answer your question, maybe there are surveys that show that maybe 60% or maybe 50%, maybe 70% with an error rate of 10%. But I think that generally speaking, if you ask doctors, they are fed up with the paperwork that are absolutely crazy from insurance company to the next. The billing, the submitting of the bill of the charges, the papers are different. If you make a tiny mistake, they will reject it. Sometimes they will also have programs that will make you make a mistake, a tiny little one number that is different, and then they will reject you so that they will delay their reimbursement, the delay with payment. And so they delay you by 30 days, 60 days. The money that they make from the interest, compounding interest, is huge. So the doctors are fed up with the kind of paperwork. If you make it so it's as simple like Medicare, every doctor loves it, okay? So when you hear that Medicare, doctors hate it, doctors gonna drop out or whatever, every single year it has not happened. In fact, the number of doctors that are now Medicare providers are all-time high. I'm sorry, but there are millionaires that are basically just doing Medicare work. They have buses that they will bus patients to, with free lunches and so forth. And if you have Medicare, you're ready to die, they're going to mine you. It's a gold mine. They mine you and milk you before you die so that you don't run out, so that your Medicare doesn't run out. So Medicare is a good program, very low overhead, and it's just straightforward. That's why there's some fraud in there, right? So but the last year or the year before, there's the record money recovered under Obamacare that went after the fraudulent Medicare billers. So if you ask me, if I have to guess, that if you simplify it, then the doctors will be very, very happy. So you have single pay under Medicare. You have single pay under TRICARE. TRICARE takes care of all of these military people, right? So TRICARE is not some kind of a whatever. It's a private insurance company, but they won the bid, and then now they're actually, taking off the top quite a bit. But we can argue that on a different day. But there's a single pay system in TRICARE, single pay system in Medicare. So whether you expand the age of eligibility of Medicare to 55 and over, or 45 and over, or you approach it from a public option point of view, or whatever, but given the American political system that we have, you just have to work the system in whichever way you think it's going to give you the best results. So do not take anything off the table. And I think that, but before you do any of that, you have to preserve the Obamacare, preserve the things that we've gained, because I think that you can launch from that, but if you go back to the beginning, it will be very, very difficult.
People in, but you've got to hold those elected people accountable. You have to be the burr up their butt, and that comes straight from Sherrod Brown's wife. She said, if you want something from them, you have to be on their case constantly so that it's easier to give you what you want than to listen to you one more time.
Hold their feet to the fire.
Yep. And that's Democrat, Republican, no matter what party they are, you need to do that. If it's Freedom Caucus, the Tuesday morning group, if it's the progressives, it doesn't matter who they are, hold their feet to the fire, stay on them, contact them constantly.
Thank you all very much for coming. As she said, if you sign up for the newsletters, Region 7, we do have a monthly meeting for Region 7, either at our house and hopefully soon at the new downtown library as we expand, because we have been getting new people showing up monthly, and we are doing things throughout the summer. We're doing events, we're going to fairs and talking to people and getting out in the community. Okay, so if you think there's nothing going on, check out the website, sign up so you can find out that there is stuff going on. Thank you.